Good evening. We are going to talk about urinary elimination and inflammation. So I thought I would go over the module lesson page. So we are talking about the concept of elimination, urinary elimination, as well as inflammation, and using the exemplars of glomerulonephritis, pyelonephritis, nephrotic syndrome, which is nephrosis, and also congenital anomalies of the urinary tract. So being able to recognize when an individual has problems, what does it look like? What does your client look like? And are there any specific diagnostic procedures or lab tests that relate to these conditions? And then talking about appropriate nursing and collaborative interventions to optimize elimination and reduce inflammation. So if there's any medications, fluids, or not fluids, any assessments, skin breakdown prevention, things like that, altered body image, and adherence to a therapeutic regimen. So I thought the best thing to do would be to go to the Alterations in Genitourinary System 2022 PowerPoint. This is one that I had put together and that has the key points in it that I would like you to know. There are some basic slides in the beginning, for the most part, that come from Giddens talking about elimination. We did a lot of this in first semester. So what is the definition of elimination? Kind of go through these pretty quickly. Any interrelated concepts in terms of fluid and electrolytes, that's a big one. Nutrition, cognition, mobility, being able to get to the restroom. We talked about different types of incontinence last semester. Also looking at fluid and electrolyte balance, because we are going to talk a little bit about potassium and sodium. I'm just going to kind of go through those. I'm not as concerned about those. As we remember that populations that are at greatest risk for issues with the urinary tract would be children and older adults, neonates, babies, and also pregnant women, because there's a lot of pressure put on the bladder by the uterus. And then the fluid and electrolyte balance is important for everybody, and usually the very young and very old are at risk. So different common diagnostic tests that you'll see, which we've talked about, urinalysis, looking at labs such as the blood urea nitrogen, the creatinine. You can do blood cultures. Is there occult blood in the stool, or even occult blood in the urine? You can do x-rays, CTs, MRIs. You can also do cystoscopies or uroscopies, which is where you would, a cystoscopy would be going into the bladder to see any structural issues in the bladder, and the uroscopy would be going up the urethra to see if there's anything, any structural problems there. You can also do different types of urine flow studies or bladder stress testing to see to check on the function of the bladder. Always look at your patient history in terms of vomiting, diarrhea, nausea, fatigue, any sudden changes in weight, either gaining weight or losing weight, shortness of breath, muscle cramping. Edema is going to be a big thing that we'll see with glomerulonephritis and nephrotic syndrome. So other interventions, again, daily weight, right? Best measurement of fluid status is daily weights. Monitoring the intake and output, of course, safety, comfort measures, oral hygiene, making sure that there's adequate fluid management. And then when we talk about how the body changes in terms of extracellular and intracellular fluid, it changes. I think the next slide is a better one here. So this is proportions of total water by age and percent of extracellular fluid. So if you compare an infant to an adult in terms of the percentage of the body that is water. An infant, 80%, 75 to 80% of their body is water. That's a lot of water. And then it decreases as we get older. You can see the different percentages here, so that by the time you're an adult, perhaps 50% of the body is water. But what does that mean if the percentage of water in the body is changing? What it's made up, the fluid is made up of intracellular and extracellular fluid. And so you can see how it changes in terms of the extracellular fluid, the plasma, being 40% in an infant and then decreasing, as you age. So if we look at that in terms of making it real, looking at weight, we take our weight of our client, if we take our preschooler who's 11 kilos or 26 pounds, and if you take 65% of the body is water and the percentage of extracellular fluid is 30%, that means that is 7.7 pounds of that toddler's weight. And so is it a good thing to lose 7.7 pounds from a 26-pound toddler? No, not in the least. Whereas if you take an adult whose 60% of the body is water, go back up there and look at that because we're looking at the toddler. The older adult, teen to adults, we're saying 60 and 60. However, because the extracellular fluid proportion is different, right? The percentage of the extracellular fluid in the adult is 20%. So 60 to 65% of the body is water in both of those people. But because the extracellular fluid is different, then it equates to 14 kilos or 30 pounds. But the adult weighs 156 pounds. So to lose 30% of the 30 pounds puts them at 126. So that's not as big a loss as 7, 8 pounds. It's going to put them at 18 pounds. So that's in terms of looking at how the fluid shifts and things to keep in mind when you have urinary elimination problems or problems with the kidneys that are promoting fluid loss. And so this just gives you some comparisons of the specific gravities. You don't have to know that information, but what I would like you to know, or to just at least remember, is the normal adult specific gravity versus the infant. So those ranges are slightly different. And we say for an adult that the acceptable urinary output is 30 mLs per hour. But for a preschooler, school age, it's 1 to 2 mLs per kilo per hour. And if it's less than a 2-year-old, so an infant toddler, then it's 2 to 3 mLs per kilo per hour. So that would be good to know. And then to review the genitourinary system, we all know the kidneys. And then if we go back, remember from anatomy and physiology, we talked about this last semester as well, looking at the nephron, the filtering unit of the kidney, and the glomerulus, which is right here, that ball. And then all the tubules and loop of Henle where things get absorbed and collected and resorbed. And then if we look at, again, some similarities and differences between adults and children, the kidneys reach their close to adult function at 6 to 12 months of age. So by 1 year of age, the kidneys are pretty much near adult function. But infants can't concentrate the urine as efficiently as older children or adults. And also because the child has a shorter urethra, we often see a lot of urinary tract infections. We covered urinary tract infection. That was one of our exemplars last semester. So there are slides on urinary tract infection, but we're going to kind of go through those to get to our exemplars for this lecture. This slide, I think, is pretty important because it really tells us the main function of the kidneys that we are concerned about. So production of renin, as we know from the renin-aldosterone angiotensin system, to regulate the blood pressure. And the release of the renin is stimulated by decreased pressure in the arterioles of the glomerulus. But basically just remember renin and blood pressure. That's what one of the functions that kidneys have. And then also the erythropoietin. So remember in pharmacology, you talked about the erythropoietin stimulating factors. And so this is again where that gets produced, and that stimulates the red blood cell production by the bone marrow. And then you also have the metabolism of vitamin D into its active form, which helps with calcium metabolism because calcium and vitamin D go hand in hand. And one of the things that you can look at is altered growth in children when you're looking for possible kidney dysfunction, genitourinary dysfunction. So that's one of the reasons we covered the dwarfism and the acromegaly, the alterations with the growth hormone, different skeletal anomalies, immune dysfunctions. And so we're going to move into the anomalies of the genitourinary and reproductive tracts. And we have some pictures that are coming up. So these would be considered the exemplar of the congenital malfunctions or disruptions in the normal physiology and anatomy. And so you can have, again, when you're doing your newborn assessment, these are things that you would find. So the urethral opening can be on the bottom or the top instead of the tip of the penis. You can have a curvature. You can also have a protrusion of the bladder. So we have a couple pictures here. We can look at that. And so there's a dorsal placement on top or the bottom, which is hypo. So that's how I remember that's on the bottom, hypo. And then epispadias is on the top. We prefer the opening. The opening is supposed to be at the tip of the penis. So we want to look for the stream of urine and to find the opening. Circumcision would be contraindicated in these instances. They can do surgical, they can fix it surgically and then potentially do a circumcision at that point. But generally that's not recommended. It's also something that the parent's probably not expecting. And so just to do some teaching about what to expect. There's also something called hydrocele, which is fluid in the sac, in the scrotum. It's around the sac that surrounds the testicle itself and causes the scrotum to swell. If it persists beyond 1 year, then it can be corrected by surgery. So this is kind of a cool picture. This is one that shows the fluid through an ultrasound. And then this one is called transillumination. They'll actually put a little flashlight there, and there's all this fluid in the sac, in the scrotum. Cryptorchidism is when the testes fail to lower into the scrotum. Usually it's one, but it can be both. And the secondary sex characteristics are not affected because the hormones are still secreted. It's just that they haven't descended into the scrotum. And so we're going to kind of go through that. They can do they can surgically bring the testicle down. They can also sew it so that it stays and doesn't go back up. And then when they do the surgery, same post-op type things that you're watching for. We do want to teach testicular self-exam. And then phimosis would be the inability to retract the foreskin. You can get what's called melanocytitis, which is inflammation of the glands of the penis. You can do circumcisions. You can give pain medications to help reduce the anxiety. There's also testicular torsions where the spermatic cord becomes twisted, which can lead to infertility. This is there's a discoloration there in the scrotum that you can see, and in here where there's no coloration, there's intense scrotal pain and testicular ischemia, and you have to do surgical correction. And it does not recur, should not recur, but it can on the same side or the opposite side. 4D is a ventral curvature, and circumcision is contraindicated. You often will see the hypospadias with the cordy, but it could just be by itself. Again, these are things that you're going to pick up on your newborn assessment. And so when you look at the genitalia, it's going to be something out of the ordinary. Would you necessarily need to know the name. It's nice to know that that's chordy because the cord is pulling the penis down towards the scrotum. But as long as you can recognize that there's something different, that's a good thing. Moving to female disorders. So this would be what's called a paraurethral cyst right there. So that's actually a cyst in the urethra. Something that's more common is called a hymenal tag. That's the little pink protrusion right there. This should look to be somewhat of a familiar picture. This would be epispadias, so openings on top, and then this is actually the bladder wall that's actually coming out. There's the umbilical cord right there as well. This is a great link that will take you to Stanford, and it gives you a lot of physical findings. For example, you can click on any of the areas, and it will show you different what it should look like. There we go, and you see the vessels. That's normal. That's still considered normal. It just shows you all kind of different things that look normal. And then if you continue on, it will continue with more. There's a meconium stained umbilical cord. Not sure that you were able to see all that. I think so. I hope so. If not, click on that link. Enuresis. Oh, that's what I was going to say. So what are we at risk for with that? Infection, skin integrity, pain, surgical repair. So we want to prepare them for surgery. And then enuresis, difficulty maintaining bladder control, bedwetting, nocturnal enuresis. Also wetting during the day, that's a diurnal enuresis. There's different medications that you can use, do bladder training, limiting fluids, keeping a diary. Again, not so concerned with that, just going through it so you know the information in case you see it. So you are always wanting to look at the urinary stream of the male newborns. When we talked about obstructions in the GI tract, but we can also have obstructions in the genitourinary tract. And so this will show you different places that you can have stenosis and blockages, different valves, and that can all cause problems in terms of the filtering of the kidneys and the ureters and problems with the bladder. And generally what will happen is that you will get the vesiculo-ureteral reflux. We talked about that last semester as well, in terms of the ureter becoming dilated and then the kidney becoming infected due to bacteria that started in the bladder and worked its way back. You can do UAs, urine cultures, bagged urine. We got the opportunity to put a bag on one of our clients in pediatrics this semester. They often come off. It's good to kind of tuck them into the diaper, but they still are going to get poop on them and come undone. And it's not the most sterile procedure, but it will give you a urine sample. And so again, that has to do with UTIs, things that can cause infants and children to be predisposed to urinary tract infections. Oftentimes, if a adolescent girl has a urinary tract infection, it could be because they're sexually active. I think we've seen a lot of, at least at Natividad, we've seen babies in the NICU where they're doing UAs because they think that the baby has a urinary tract infection. Yeah, no bubble baths, or not a lot of bubble baths. And then there's different clinical manifestations in the infant or in children. This infant can't really tell us what the problem is. And then collaborative care, different antibiotics, wiping front to back, cotton underwear, that type of thing. So now we're going to move on to acute glomerulonephritis. So we covered the congenital defects, which was one exemplar, and now we're going to move on to the acute glomerulonephritis. And so when we're looking at glomerulonephritis, again, we're talking about the glomerulus, which is part of the nephron, the functional unit of the kidney. And the glomerulonephritis is generally related to a strep infection, some type of infection. It's a reaction. And then it damages the glomerulus, which then the glomerular filtration rate decreases because the kidney can't work effectively. It's no longer an effective filter. You'll see it often in children ages 5 through 12. So acute glomerulonephritis, which is something that would happen quickly, would be post-streptococcal. So after certain strains of group A beta hemolytic strep infections like impetigo or strep throat, usually within about 2 weeks, you'll see hematuria, so blood in the urine, proteinuria, protein in the urine, and oliguria, decreased urine output. You may even see gross hematuria, gross in terms of looking gross, as well as being a lot of blood in the urine. And so it's actually sort of a tea-colored urine. There is protein in the urine, not as much as nephrotic syndrome, but there is protein. Most children recover within 2 weeks. Can also be associated with systemic lupus. And so if we're looking at it at more clinical manifestations, so mild proteinuria, the smoky or tea-colored urine, there's tea there. You can have hypertension because there's some extra fluid overload and the damaged glomeruli, so perhaps headaches. The child will start to get headaches, decreased urine output, some abdominal or flank, so in the back, like kidney kind of pain, sometimes a fever, crackles, pulmonary edema, because there's extra fluid. The kidneys are not filtering out. They're holding on to fluid. So when you get lab results back, you're going to do a urinalysis. And so there will be RBCs in the urine. And then the CBC, potentially normal WBCs, because that infection has already been fought off. But there will be decreased RBCs because of the destruction in the glomeruli, and then you get blood in the urine, and that goes out of the body. There may be strep positive, the throat or skin culture could be strep positive, or one of the things is you might see a positive, what's called ASO titer, an anti-streptolysin O titer. So that indicates the presence of antibodies against strep. So if you see the antibodies, then you know the strep was there. Low serum complement, but usually the positive ASO titer is what the big indicator is. So we're going to move on to nephrotic syndrome, and then we'll do a little bit of a compare and contrast. And that's what I would suggest, is that you make like a compare and contrast for glomerulonephritis and nephrotic syndrome. So in nephrotic syndrome, there is increased glomerular permeability, and you get albumin excreted in the urine. So there's huge proteinuria. The protein is excreted in the urine, and so you have decreased protein in the plasma. So as compared to glomerulonephritis, there is much more protein lost in the urine. And then you end up with edema. You see poor little girl there with the edema, because you have decreased protein in the plasma. And so there's a decreased oncotic pressure, and so you get edema, which is seen in the face quite clearly there. There's minimal change nephrotic syndrome, which we would consider to be idiopathic. It occurs most frequently in children 2 to 5. greater than 3.5 grams per day gross proteinuria. And then our friend Gary Coleman there, who had nephrotic syndrome. This is just a diagram in case it would help you to understand where the edema comes from in terms of the pressures, because you do also see a hyperlipidemia with nephrotic syndrome. And so if you're looking at interventions, the interventions, nursing interventions are very similar. So again, daily weights. We might check abdominal girths, testing for doing urine dipsticks for specific gravity, protein, blood, strict I's and O's. The diet, no added salt or low salt. People would think that, you might think that because there's such a loss of protein in the urine that we would want to increase or have a high protein diet. However, if we add more protein, the kidneys aren't functioning at full capacity anyway. And if we add more protein, it's just going to destroy the glomeruli more. So we don't want to have a high protein. We want protein, but we don't need high protein. And then generally speaking, we're going to have diuretics to decrease the edema, prednisone, which will help with the systemic inflammation. And then if there are blood pressure issues because the kidneys are being affected, there might be some antihypertensives. With the swelling, there can be body image issues. So we want to promote rest. And there's risk for infection. That's one of the big things. So don't give live virus immunizations, which I'll let you remember what those are, the ones that you find in the fridge. Monitor the visitors. And so here's something I think is kind of clever for the acute glomerulonephritis, which is had strep. So hypertension, the positive ASO, the decreased GFR, swelling, the tea-colored urine, recent strep infection, elevated BUN, creatinine, and then proteinuria. It's just more of a mild proteinuria in the glomerulonephritis. So here, if we look, looking at both and kind of doing still more compare and contrast, there will be the acute glomerulonephritis, protein and RBCs are lost, whereas in the nephrotic, it's mostly just the extreme amounts of protein in the urine. And so collaborative interventions with our medications. Remember, you always taper prednisone, and that's milligrams, 60 to 80 milligrams per day, would also be based on kilograms. Since we're losing protein, we're going to give albumin IV, furosemide, no added salt, antibiotics prophylactically. We don't need to give antibiotics with the glomerulonephritis necessarily unless there's a persistent strep infection, because remember, this happens generally 2 weeks after the strep infection. Possible fluid restriction, diuretics as well. And then, so that would be those. Wilms tumor isn't on your list of things, but it is kind of, I think, a cool thing. And I have seen it come up on NCLEX sometimes. So it's nephroblastoma. It's a malignancy, potentially having a genetic basis and mostly discovered before the age of 3 years, often around 2 years. No symptoms, few symptoms during the early stage of growth, and the child can't really notice a difference and couldn't really tell you anyway. And often the parent will feel an abdominal mass. So even though this is a tumor, a kidney tumor, it gets so large that you can actually feel it in the abdomen, or the child will be very sensitive in the abdominal area. And so if you do an IVP, intravenous pyelogram, it will reveal the growth. And what basically happens is a tumor compresses the kidney. It just takes over the kidney. And it usually has a membrane around it. It's encapsulated and oftentimes will cause hypertension. And there's a picture here. And they're going to do surgery, radiation, chemo, try to remove it as soon as possible. And so I don't think I can I make that bigger? So this is actually, whoops, that was not what I wanted to do. So here is actually, I don't know if you can see, here's the kidney, and this is the ureter here. And so this is the tumor. That's huge. You can kind of see there's sort of a membrane around it. This is bleeding in the area there. And so if you are the nurse receiving a child that has a Wilms tumor, you don't want to be doing abdominal examinations. You don't want to be palpating around the abdomen because it can hurt, and it can also potentially dislodge or break apart the tumor. So necrosis and blood. You can see the kidney and the ureter there. And then the last few slides have to do with acute kidney injury and chronic kidney injury, which you're going to talk about more in third semester. Just to understand, acute kidney injury will have an onset and then be concluded, whereas chronic is an ongoing kidney problem. So you have things that are what you would call pre-renal. So before the kidney injury, intrinsic having to do with the kidney itself, or post-renal being after the kidney. So if you start with post-renal, it's an obstruction. So it's doesn't have to do with the kidneys. It's after the kidneys have filtered out the urine. So there's some kind of obstruction. So like a kidney stone, something that will decrease the function. If it's intrinsic, then it has to do with the kidney tissue itself. And then something that's pre-renal would be conditions that decrease perfusion of the kidney. So something like hypertension or diabetes would be something that was pre-renal. So you'll see a decreased GFR, decreased urine output, azotemia, which would be elevated blood levels of urea, uric acid, and electrolyte imbalances. And so you might see diuresis and voiding large amounts of dilute urine. And so dehydration is pretty common. So keep them hydrated. And then the function generally will return once we figure out what the cause was, if it's pre-renal, intrinsic, or post-renal. With kids, it's always decreased appetite, lethargy. You could see seizures. They could be pale, poor feeding. And so to determine the cause is really what's very important. And so looking at the history, the fluid volume status, we can do labs and try and figure out what's going on. Hopefully dialysis is not needed, but if there's severe fluid overload, congestive heart failure, pulmonary edema, those types of things, then dialysis might be indicated. That just gives you a definition. And then chronic kidney disease and failure, so irreversible loss, end-stage renal disease. We see this a lot. I think some of you are on the dialysis unit in first semester. And so you may see those will be adults, generally speaking. Children would go to a specialty center to have dialysis. But multidisciplinary care, sometimes kidney transplantation. I did take care of a girl when I was doing home care. This particular client was when I was in Pennsylvania. And I was caring for her the night that she got the call that she was getting her transplant. So that was kind of cool. And so that takes care of that. So the main things to know would be able to compare and contrast glomerulonephritis and nephrotic syndrome, and to be familiar with those congenital disorders that we talked about. You know about that. Okay. So just pictures of what an infected kidney versus a healthy kidney. This is the study guide that the comparative study sheet from Nurse Mike. And again, glomerulonephritis is the inflammation and scarring of the kidney that typically follows a strep infection, maybe 2 weeks after. You will see protein loss, but not as much as in nephrotic syndrome. Fever, the WBCs could be high, but they might not be high, because if the strep infection is over, then the WBCs may have recovered. You're going to see that ASO titer. that shows that there was a recent strep infection. Different medications that you might see. Remember, those medications are potassium wasters, so watch for your hypokalemia. And we don't necessarily want to limit protein. We just don't want to have high protein. Definitely want to treat the infection. And then for the nephrotic syndrome, often considered an autoimmune disease. Now, you can also see glomerulonephritis with an autoimmune disease, but nephrosis generally has to do more with stress, sickness, could be anything that's going to initiate an immune response. And so you are going to see more protein loss, low albumin, so you're going to be have hypoalbuminemia. And then you can get to a hypertensive crisis and kidney failure, maybe headaches, nausea, vomiting, no or low urine output, rapid weight gain. Because remember, with nephrotic syndrome, you get the more rapid swelling. Glomerulonephritis, you do get edema, but it's not as rapid of an onset. And remove the trigger. They might be on antibiotics. You don't necessarily want to increase protein. You just want it to be regular protein. We don't want to stress out the kidney. And then you have pathocharts for both of those that you can look at. There's showing you the medulla and the cortex of the kidney and the nephron. And then there's a couple articles here, pages that you can go to. Nephrotic syndrome. They're looking at the edema in the face and the protein in the urine, tachycardia, and hyperlipidemia is another sign you might see. And then I did go ahead and post a key for the questions, so you can go through the questions if you'd like, and then you can click on the key, which will take you to should be published, yep, and give you the answers there. And I believe, yep, the videos. There's our purple nurse Sarah there with her videos. And I do believe that that covers everything that I wanted you to know. So I'm going to stop sharing. And it is getting close to bedtime for me, believe it or not. And so I will let you go and let me know if you have any questions. Have a great rest of your weekend.